Well, good morning, good afternoon, good night to the PICU to this PICU Perspective podcast. And I'm thrilled to be joined by Samer Abu-Sultaneh. That you Samer, are from Jordan, but you are currently in a position of associate professor of clinical pediatrics at Riley's Hospital for Children at the Indiana University Health in Indianapolis. So you are based in the US. And you are the lead author and co-chair of the first ever pediatric mechanical ventilation liberation guidelines. So today, this is my first PICU Focus podcast. So I really wanted to thank you for your time. And I think it would be a wonderful podcast to speak about this fascinating topic about liberating kids from the ventilator. So my first question, Samer, is why did you choose this topic? I mean, why you are so interested in liberating kids from the tube and from the ventilator, and in a way from the pediatric intensive care unit. So how did you start in your career, and why are you so keen on doing research on this topic, and how did you to lead this amazing effort?
Thanks, Sebastian, for inviting me. Very exciting topic for sure. So when I was in fellowship, we were part of the Restore trial. So we were doing the daily screening for SPT, and we were doing SPT in a standardized fashion in Milwaukee. So when I came and start my work at Riley, I noticed that there is no standardized way. Some people use different ways to liberate from mechanical ventilation, and mostly it was led by physicians. So physicians will decide, like, let's put this patient on a spontaneous breathing trial and see if they will pass or not. So there's not a standardized process of doing it. And I was reading more about it and got interested in why RT cannot do the screening process, and us decide on objective criteria, that if the patient meets it, patient will go on a spontaneous breathing trial, and we have an objective criteria for passing SPT, and if they pass, we will recommend extubation. And this is what RT would do and documented in our EMR. So we did a study as a quality improvement study, and we were able to decrease our extubation failure rate from 7.8 to 4.5, I think. So it was fascinating that this work can be done. And we did more projects related to RT-driven protocols. But with that interest was the interest about ICU liberation from SCCM. As we know that the B element is the core element of the ICU liberation. If we think about, our patients who are worried about sedation and pain, immobilization, a lot of it is related to have the tube in. So can we take them off a day before? Can we prevent them from having extubation failure? And, talking about long-term effects of these sedations, if we save them some days that they are not receiving sedation medications, for sure, will decrease potentially the post-extubation syndrome. So that's how we got interested in the process initially, like we need to do the vent liberation work.
And well, of course, these are the first ever guidelines. So that made me think about why did, as a pediatricians, took so long to try to organize our work in this intervention. I mean, as you were saying, ventilator is what makes children be the PICUs for most of the time. Perhaps more than half of the children currently today in the PICU are because they need a ventilator. And you were saying that, well, with simple things, organizing your work, your team, you can reduce the exposition to the exposure to the ventilator. So why did it take so long, and why children are not adults? Because many times we are used in pediatrics to do many things that adult counterparts do, but that might not be easily translated to taking care of kids. So why did it took so long to make these guidelines? I mean, we are in 2022. Fortunately, you did this amazing work and gathering this awesome group of physicians and nurses and researchers all around the world. But we have, it is a long road since pediatric intensive care developed. So why it took so long?
You are completely right. Yeah, it takes us longer, like pediatrics. If you think about the vent liberation guidelines from adults, they publish it, way before us. Some of it is related to the evidence, how much evidence we have, and sometimes how long it takes you to generate the evidence. It's not a simple task to ask the experts to come and spend 2 or 3 years evaluating the literature. And so it takes time. It takes effort from everybody. So I was fortunate that Robbie supported me with this proposal. We submitted this as a grant, and we got the grant to support the conference. And many of the experts like you, Sebastian, when you send them the invitation, they were excited of doing the work. And I think it just takes time. It just your time takes everybody's time. So I think this is part of it. It's just how much literature there was before. And in the last decade, there was more literature related to vent liberation. So I think we're situated better, to generate the guideline. But also the goodwill from the experts that they did this work for free, spend time to put these guidelines together.
Okay, and well, you can speak a little bit about how was the process of gathering the experts and friends, currently friends all around the world in the midst of a pandemic. I mean, I think the pandemic disrupted in a way your plans. So when did you start with the idea? How many years took to you to propose this grant, to get it, to gather the experts and to do the guidelines? And perhaps you can walk us through the process, how we did it, how was the process of making the guidelines, and what makes these guidelines unique in a way.
Yeah, so the process, as you know, is long, and that's why guidelines are harder to generate. So we started chatting, me and Robbie. I introduced myself to Robbie 2018. I told him, what do you think about an idea about the guidelines? So he said, yeah, this is interesting. Let's meet after PICU meeting, which we met. And then the following PICU meeting, which was 2019, we had a formal, sit down, and we start working more, inviting a smaller group of experts. We generated or established an executive committee to look at these, questions, how, looking at the scope and how much questions we can answer with available literature, and also being mindful about be able to generate the guidelines with a reasonable time frame. We don't want to spend 5 or 10 years generating a guideline. We need them to be
it took
up
so for almost 5 years. So it takes time.
About 4 years. Yeah, it takes time, about 4 years. So we submitted the grant. We submitted a proposal society. We got great feedback, but always the concern about pediatrics, and this is not the first time, we submitted another thing after these guidelines for consideration. And what happens is everybody in pediatrics would say, you guys don't have strong evidence. If we look at the TBI the same way, if you look at, the ARDS is the same thing. We don't have huge RCTs as adults. So that's a challenge for pediatrics in general. So we got the feedback from that society, and there was a great opportunity by the NIH, for what they call R13, which is a consensus conference. So we submitted that, and we got a great support from the NIH officer to support this work. And we gathered the team. So the team was, we looked at the literature, and we looked at who published in this area, who's interested in this area. And we also, as you mentioned before, we tried to make it multi-professional. We didn't want just to have physicians. We know that vent liberation is a multi-professional process. We have our nursing, we have our RTs, we have our respiratory physiologists. They need to, when we think about the vent liberation process. So the whole team, we gathered the team from experts, and we send them invitations. It was hard, as you said, during COVID, because we started the first meeting just after COVID. Just after COVID
it was
started.
planned to be in person, and it wasn't. It was Zoom, many meetings, Zoom, a lot of Zoom work. But well, we arrived to make it happen. So what did you learn through the process as a lead investigator? What can you say for those PICU physicians and researchers who might be right now interested in a topic, which consider relevant to make research and to make, what would be your advice to start the process of making a guideline?
Yeah, we are in the process of thinking of another guideline. Actually, we started
Okay.
2020. I think the first thing is the topic important? Is that right? Like, do we have a lot of variation? Do we have a lot of patients? Can we decrease this variation? And with decreasing variation, for sure will improve care. So do we have big population that need to be served? One thing I think is important, as you know, during the process, Sebastian, is having a great team. The team is all of the work is related to the team, because it's not one person or two people, leading the work. The whole team need to be invested. So I think trying to make sure that the experts in the field in that topic are involved, but also include people that you think they have the energy and investment of doing this. A lot of people, are busy with other things. So make sure that people know what they are committed for and what's the timeline. Sometimes also the scope is very hard for people when you talk about guideline development, because if you think about the topic, you might have like 20 things that you need to discuss. And this is an advice from our methodologist, is like the scope. Again, when we submitted for other societies for different topics, it's like the scope, not more than 6 or 8 PICU questions that you're trying to answer.
Yeah.
You might get sub questions or some.
So stop, Samer. You won't be able to answer all questions. I think
Exactly.
that was a suggestion. Yeah.
Yes, focus on the thing that you can finish, because guidelines, if the advice that I got is, if you don't finish it within 12 to 18 months, people will lose interest, and then you will not be able to finish the guideline within the time frame. So start with the most important 6 or 8 questions that you think there is importance for these questions, and also there is some evidence that you can generate, recommendations. So the other topics could be important, but they could be you can publish them as a white paper or position paper or editorial or something else that people need to investigate this more.
So there is a saying that you have to make a research, you have to be really angry on one topic, you have to say, hey, why didn't you extubate this kid? I mean, he or she was ready to extubate like yesterday, That's my clinical practice. I love this topic, liberating, because it is a real liberation. And I think that the naming of the guidelines, I mean, the concept, the conceptual framework is liberating kids, because most of them perhaps don't need the ventilator. So perhaps they needed it during the most critical course of the disease. But then there is another saying that says that perhaps more than half of the time they are in the ventilator, they might not even be needing it. So what made you angry before you started these guidelines about your clinical practice? You take care of critically ill children from so long ago, and what you named about variability of care, how clinicians did different things in different times in a different fashion, and how that has impact on the care, because you are really involved, Samer, in quality improvement initiatives, and that's another scope of your research. So there was something that made you angry about not extubating kids, and how this guideline that you led changed your mind or your focus on this topic?
Yeah, that's that's a very complex question, because I think every time you try to extubate a patient, you would say, oh, should we done this in a different way? So the things are, you will notice them in the guidelines, but there's different questions that you think about is, do you need to use steroids or not using steroids? Do you need to extubate all patients to high flow? You notice that some people would say, oh, I would extubate every patient to high flow. I would not extubate any patient to nasal cannula or room air. Or, I don't use CPAP or BiPAP. So trying to gather the evidence, because I think now still, in my institution, other institutions, there's still room for improvement in different areas. And I think the first thing that was, as I mentioned earlier, that was a little bit annoying, that we don't have a standard. Like, when we talk, you come in the morning, somebody would say, oh, the patient failed the ART or SPT. It's like, failed for what? Like, what exactly they failed for? Like,
what did you measure?
It's like they were a little bit sleepy, and that's why they are, they didn't pass, and you need to adjust stuff, or they don't have a leak and you're worried about upper airway obstruction and you give them steroids. So the communication part, other than there was no standardized way, the communication was the most frustrating part, because there's no way to know what happened during the night. It's just a verbal communication. So just trying to standardize the way even of documentation and communication, because when you go to the EMR to say, oh, this patient passed because they were bradyapneic. So you can say, oh yeah, maybe their lung mechanics is okay, but their level of consciousness is not perfect. So let's wean their sedation and maybe try another spontaneous breathing trial and extubate them later. The same way with a leak. If we know that the leak was not there, we'll give them steroids, for example, if your practice is that way, and maybe extubate them later. So even not delay them for the next day, but extubate them later in that day, save them at least 12 hours from the extubation. So, but that comes with different things. When you practice for a long time, there is cases you say, neuromuscular patient with a neuromuscular disease. We say, yeah, maybe we extubated the kid to high flow, but in reality, and eventually failed. In reality, maybe this patient need to be extubated to continuous BiPAP and try to bridge them to be on a list support afterward is another way. But I'm sure that, Sebastian, from your work, the same way that you feel there is stuff that we can do better.
Yeah.
We can think
there
about
is a sense in the air that we were very slow in the process of liberating the kids. At least in my view. I mean, many people think that I am like obsessive about getting the tube out. And I know that many times there is a very difficult risk versus harm versus the risk management in these kids are really difficult, particularly in units with high technology dependency kids. I think that would be the case in most of the high-income countries. Perhaps later on we can discuss a bit further about the difference on the implementation of these guidelines, whether you work at high-income countries or low middle-income countries, because you were saying respiratory therapists, and in many countries there are none. You have nursing in a ratio which is really inadequate. So the implementation of these guidelines are challenging. So, Samer, what are, in your view, or how did you receive the results of the process of the guidelines? And did the guidelines change your clinical practice? What are the main messages you learned about the process and the things that came up during the guidelines? We performed many systematic reviews, we dissected the evidence, but for a general audience, pediatricians who might be listening to this, what are your main messages, or what did you learn to say to a colleague who is right now planning to extubate? So what can these guidelines change in your mind and in your clinical practice?
Yes, so I think we try to hit different aspects of the extubation process, from screening, what kind of CPAP or pressure support spontaneous breathing trial to use, give some guidance on the duration, muscle strength, leak pressure, steroids, non-invasive respiratory support, and then sedation. I think it depends on, as you said, it depends on your institution. I think you need to study what's in your institution. Where is the areas that need to be improved upon, and which elements of the bundle would be low-hanging fruit for you. Because if you're trying to apply something like at once, you might fail.
Yeah.
So try to see which one is based on your, unit culture, based on your unit resources, which things that you think that you can get buy-in from the team. Say, let's try this first. Don't get in the most controversial thing in your unit and say, I want to do a dramatic change in this area.
Yeah.
Try to see which area that you feel that there's a deficit, and try to find an element or elements that you think would work best and improve care for patients, and then you can move to the next element.
So these guidelines to your context, first thing, and try to think what are the key topics you have problems with, and then adapt them. I mean, because many people think that guidelines are like you are forced to do what guidelines say, but perhaps many things that we recommended don't have strong support from the evidence. There are many open questions, but it is important that to state that adapting the recommendations and the guidelines are key here. Yeah,
you're exactly right. You know based how we based the guidelines was based on the evidence that we have, and even having in some of the questions some RCTs, and some of the RCTs were large. But when you try to make the recommendation based on the grade methodology, and you go through the process from evidence to decision support, and you move from trying to put different things. It's not just the evidence, as the evidence to decision table will guide you through. There is patient values, there is resources, there is a lot of other things that you need to put in mind. And even our recommendations are conditional. And what means conditional, that you should consider them in many patients, but you should consider what's your your environment, what's your resources, what's your patient population. If your patient population, most of your patient population are low risk extubations, you might go with one way. If you have a higher risk population, you might go with a higher risk, a higher risk for extubation recommendations. And learn and adapt when you implement these guidelines. Because, for example, I'll give you our example. When we implemented our protocol in our hospital, there was no guidelines. We searched the available evidence at that time, and we came up with our protocol based on the evidence that was available at that time. And with that, even having a protocol, but just a protocol, like everybody try to extubate in the institution in the same way, we still have some variation. We have variation. We are not completely 100% compliant with the protocol, but still our outcomes just got better just by having a protocol. The details of the protocols are important too, but what's most important is having a way in the institution, because it has a lot of benefits. Decreased frustration between providers, family, and staff, and everybody knows that this is what we based on. And you can have deviations based on the risk assessment for the patient, depending if the patient is a patient with a neuromuscular disease, or a patient with traumatic brain injury and poor control of secretions. So you adapt and you think how you adjust your extubation or liberation practices based on the patient's condition.
So how did your clinical practice change? Did it change?
It didn't change too much, because
not
we have
much.
something that is cooking.
Okay. Yeah, but for example, you have a child admitted to the PICU like 48 hours ago. It's on the mechanical ventilator. He's tubed. He has RSV disease, regular disease. What would be your recommendations based on the guidelines? What to do, what not to do with that kind of a kid? How would you stratify the risk of extubation, and what things would you recommend in a regular kid in the PIC, like bronchiolitis, RSV, bronchiolitis? I mean, they are all the same, but they are all different. So what would be your recommendations?
Yeah, you're exactly right. You know, the
Samer.
I'll go with the recommendations from the guidelines. So if you are, if we need to dissect it by one, I think the most important thing is just to see where is the patient from two risk categories. The first one is the patient at risk for extubation failure based on some of the criteria that we put in the guidelines or a list of criteria. It was not, 100% comprehensive, but this is what the experts came up with based on the literature and our experience. So is the patient at high risk for extubation failure is one thing, and the other thing is the patient high risk for upper airway obstruction. So you think about it, I think the most important thing is to do at least daily screening, if not more, maybe twice a day. Some people do twice a day screening to see if the patient would be able to go on an extubation readiness trial and an SPT. So I think this is the most important thing. So
to be actively screening if that kid needs the ventilator or not. Yeah.
Exactly. So, at least, as I said, every day, but maybe every 12 hours, is their lung mechanics improving and their disease is improving and they are nearing extubation. And now the criteria, we put some suggestions in the guidelines based on the published literature about what things you look at and different things from a ventilator standpoint, hemodynamic standpoint, and CNS standpoint. And you look at this patient, this is the patient nearing extubation in the next few days. You screen them every day, if not every 12 hours. And then you think about, are they at risk for upper airway obstruction? One of the things that we discussed is checking a leak pressure, especially if you have cuffed ET tube. And if the patient doesn't have a leak, and if they are also at a risk for upper airway obstruction, if they had traumatic intubation or multiple attempts, if they had a surgical intervention for the airway, you might think about using dexamethasone for these patients to prepare them, because as we know that extubation failure is multifactorial, and upper airway obstruction is still reported to be the most common reason for extubation failure in our kids, but still it's multifactorial. And after that, if the patient meets your objective criteria for screening for an SPT, you put them on an SPT and see how they do.
Yes, well, as you name it, steroid thing has been a hot topic during the guidelines. We made a network meta-analysis about it, but many people I walked and I read in social media and some conversation, online conversations, that now we have to give steroids to everyone from a long period of time. So I would like to talk about it because Hari Krishna from the UK was sending some questions to you about this. So do you think the guidelines will increase use of peri-extubation steroids because of a recommendation based on very low certainty? How will we measure the unintended harm related to the use of steroids? And just to give you a hand on this one, this difficult answer, I recall every day to my fellows and residents that do not delay extubation for steroids if the child is low risk upper airway obstruction or lower risk to extubation failure. So what do you think about this?
Yeah, I think it's a great question, and I think I will answer it in two ways and see how we handle it during the guideline development, because there was concerns about delaying extubation to give steroids, which was one thing, and overuse of steroids. If we look at the evidence, actually there is a lot of RCTs related to this topic. And as Kevin Wilson, the ATS chief of documents and guideline development, he praised the team, and we have Dr. our methodologist, for using a novel methodology during the guideline development, which is the core methodology and the network meta-analysis. And that, the question about the steroids is an important question. And people ask always, like, do we need to give steroids or not? So if we look at the RCTs, the discussion was, if we need to take the RCTs just based on the RCTs themselves, we would recommend giving steroids for everybody. And the discussion was, this is not the right thing to do. We need to stratify patients to a high risk and a low risk for upper airway obstruction, both not to expose the patient to steroids, which is the first thing. And the other thing is to give them the steroids in a timely fashion so we don't delay extubation for the steroids to work. So we did two, Sebastián, you are part of the team that this question and the two publications came from. Other than the actual guidelines, there is a network meta-analysis paper talking about this. But we tried to stratify how much steroids you need. Do you need a 0.5 per kilo of dexamethasone to be given, or do you need a lower dose? And do you need to use it early or late? Do you need just to give it an hour before, or do you need to give it 6 or 12 hours before extubation? And what we found in the network meta-analysis, which is a very interesting method of generating a recommendation for that question, because it's never been used for guideline development, as I mentioned, is giving steroids early, whether it's low or low dose or high dose, would be the first, would be ranked first. And then if you are in the 6 hours range, you need to give a higher dose. This is based on what the literature is. So how to avoid delaying extubation to give steroids? I think that question came when we did this framework, which is a nice, colorful, framework, is you need to evaluate your patients. Are they nearing extubation? Are they going to be extubated 12 to 24 hours before? And with that, you check a leak pressure if they have a cuff ET tube, which most of us now use more cuffed ET tube more than previous decades. And you evaluate their risk for upper airway obstruction. And then if they meet one of these high risk criteria, we suggest giving steroids. And that's how we I think avoid giving too much steroids for everybody, and also trying to give it on time so we don't delay extubation.
But if you have the kid ready to be extubated, he passed the SBT and you forgot the steroids, and he or she is a low risk subgroup, for just give him or her a dose of steroids and you will find. Or it's not a sin not to give steroids to that kid. The sin would be delaying the extubation at least 6 to 12 hours to give steroids, and that's an important different point to be clear about it. That's exactly why Harry asked this, because we can be overusing steroids, and as well we detected that we have randomized data about upper airway obstruction, but we don't have strong evidence stating that giving steroids in a high and early dose reduces extubation failure. There is a tendency towards better outcomes, but extubation failure, it's not yet proven. Yeah,
you're completely right. And as we mentioned before, it's complex. It's a complex topic because extubation failure rates are usually not too high, which is good. But also extubation failure by itself, it's multifactorial. So I think there is an elegant paper from Robbie Kimani about, the upper airway obstruction risk and muscle weakness. So if you have two elements, if your respiratory load increase and your respiratory capacity is not great, your extubation failure rate will increase. And that's a thing. I think people need to think about it. And this is how you combine upper air obstruction with other risks for extubation failure. It just using extubation failure by itself is a tricky outcome just because it's multifactorial. So there's many things that they are harder to account for. And the other thing that we mentioned, and maybe it's worth mentioning here, is even with the upper airway obstruction, which we discussed multiple times during the guideline development, and hopefully, you know, with future work that is coming, that we standardize how we classify them, because there's the supraglottic and there is the subglottic, and there was a big discussion. But in these studies, still,
Yeah, I recall
that. They didn't differentiate that, and it's very important. And I think the team from CHLA published a great paper about this topic too. So I recommend everybody reading it too, from CHLA team.
I will have Robbie the next week. So
Yeah,
many things to be discussed. So we can dive now on the SBTs, the spontaneous breathing trials. Some questions arise about these, our recommendations about does the TPs need to be abandoned? So we favor using CPAP, and you can further discuss about this interesting recommendation about perhaps in high-risk patients, CPAP only would be better than CPAP plus pressure support. We have observational data about it. And what about the duration of the SBTs?
Yes, let me answer the question about duration, and I will answer the TPs, but I would leave the CPAP question also for Robbie.
Okay.
Because I think Robbie would be very interested about interested about answering that question. I think the duration is challenging. I think, and that's what we found in the literature, because most of the literature, everybody use 120 minutes, and the question would say, can we use a shorter period? Meaning that, do we need this kid to be on 2 hours to make sure that they are, they will be able to extubate? And is 30 minutes or 60 minutes enough? Now, some people say, oh, it's 15 minutes is enough. So the question is, how long is good to test the patient capacity to be maintained on a SBT? So we'll make sure that when we extubate them, they will do fine. So the challenge is there is now no RCTs in that area. And this is when in the recommendation or the guidelines, we recommended doing more studies regarding this. And if you look at the adult literature, they did some studies regarding shorter period of SBT. And they found that, both of them perform similarly. But we don't need to extrapolate data from adults, as we said. And that's why, our physiology is different in kids, and we explain it well in the guidelines. But do we need to do for everybody? Do we need to do 120 minutes? So there was no RCTs or even observational studies looking at this question when we generated the guidelines. Now, there was another study published after the guidelines looking at this question, but it's also physiological observational study. So it's not an RCT, and it's just looking at different respiratory physiological parameters looking at that question. So we did voting, and we divide the patients to high risk versus standard risk. And even the high risk, as you can see from the recommendation, we still said that both of them, 30 or 60 minutes or 120 minutes, should be fine. But you need to stratify it maybe based on the extubation risk, whether they are standard. If they are standard, you might be okay with 30 to 60 minutes until more evidence is available. If you are a high risk, you might need to test them for a longer period to make sure that they don't pass 60 minutes and we say they're okay. But if you put them in 120, they fail the SBT. So I think this is how we handle it based on limited literature. And this is one of the questions that we actually had no literature looking at that question specifically.
But it was a recommendation that the higher the risk of the patient, the harder you make the SPT to that patient. Try to avoid overestimating he or her capacity to be extubated, right?
Yes.
So at least 30 minutes and between, because another question arises about, well, SPTs to be conducted for either 30 minutes or 60 to 120 minutes, depending on the patient risk of extubation failure. You were talking about this. But for standard risk patients, SPT's duration between 30 and 60 minutes were considered the most appropriate. So for this kid, this example with bronchiolitic kid, 28 hours, 48 hours or mechanical ventilator, just an SPT of 30 to 60 minutes would be okay if that kid is not high risk patient.
Yes, and this is again, you need to take that we didn't make a recommendation on this specifically, but we made some remarks based on the voting. So there's no evidence. So what we need to do is, like, for this question is more the expert opinion in a way. And this is how we try to formulate the expert opinion in this question, to give people guidance, because we didn't want just to leave them with either. We need to give them, like, what a group of 26 experts would say, what's the most appropriate time. So we asked them to score that from 1 to 9, and 7 to 9 would be appropriate, and 1 to 3 would be inappropriate, and the middle scores will be still there is equipoise. And when we did that voting, the standard risk were 7 and 7 for 30 minutes and 60 minutes, and it was, I think, around 6 for 120 for that standard risk. And for patients with different classifications of risk, most of them were 120 minutes. I recommend people looking at the appendix. I think it's that first table in the appendix. But most of the experts feel that we still need to do 120 for most of the patients. Now, again, the evidence, we need more evidence in this question. So we try to give guidance, but still we don't have evidence.
Can you talk about a bit about how do you foresee this guideline to be implemented in the future? What would be the research areas we detected? How will you think these guidelines 5 or 10 years from now? How do you envision this liberation of the ventilator for the coming years?
I think it will stimulate people to do research in this area, and it will focus them on the PICU questions that we try to ask. So I think we still, many people still have questions about using CPAP or pressure support, especially that we depend on our recommendation based on physiological studies. We didn't have any RCTs, so this is an area open for that. Duration is the same thing. Talking from Harry about the threshold for the BI max and how to do this. Like, there's many questions that still we can do RCTs on. It's interesting that there was a publication from the CHL group about the duration after this guideline. And there was, during the European conference just recently, somebody from India published or presented an RCT that they finished about the CPAP pressure support SPT question. It's a small RCT, but as we know that our RCTs are smaller, it's like 110 patients or 120 patients in each arm, which is it's a good size for pediatric sizes for the tiny people here. So I think it will stimulate more people doing doing more RCTs in this area. And the bigger thing would be trying to collect more observational data. If there is observational data, more observational studies directed to these PICU questions, and eventually working on implementation, studying what's your landscape in your institution. We published a couple of papers with Jeremy Loberger about the landscape of extubation or vent liberation practices worldwide. So I think everybody need to look at their practices and see where is the areas. Talk to your respiratory therapist, talking to your nurses, talking to your residents, talking to your team, and see what areas of I would say improvement that you want to work on and standardize in your institution. So implementation science, I think would be a big thing, both to improve the outcomes, but also to generate more observational data that can inform modifications of the guidelines on the second version. These guidelines get updated, and we are planning to update them in a regular fashion. So as there more literature, is created, we would update the recommendations, and we might not go with even wait 5 years if there is enough literature, to update a PICO question.
Okay, that's
maybe
interesting.
We'll use maybe we'll use the AHA kind of, and the same thing that ECCM used to update the COVID guidelines. As the evidence get generated, for a specific question.
Once you have this structure made, you can update regularly the guidelines. Prior to the publication of the guidelines, the first ABC results trials from the UK were presented. So there is a more clear question regarding what to extubate, the respiratory support, what is high flow or CPAP better. Perhaps you can speak a little bit about that, how we received this. We have to update the recommendation with the results from the colleagues or from the UK. What do you think about this?
Yeah, as you remember, we were waiting on the guideline, and or the first ABC trial to see if we'll be able to include it in the. So our infrastructure, we know we have the search terms and librarians ready, and this is the nice thing. Even talking about the CCM, COVID guidelines, if you see them, that they have an infrastructure that if the evidence gets generated, you update your literature search, you do the screening process, you extract data, you put it on the updated evidence to decision framework, and with the experts that we have, you can update the recommendation and vote.
Living guidelines.
What's that?
Living guidelines.
Exactly. And we tried to do this because we didn't want to leave the first ABC trial. Why we are publishing it? Because we were in our first draft of the manuscript. So we felt very good about with having the infrastructure and commitment from the experts that we can extract the data, do a again updated screen, because we did a updated search to catch other articles that related to the area. And we added the first ABC recommendation. We voted on it in 2 weeks, and we updated the manuscripts, because updating the manuscripts at that time was not as painful as creating the whole thing.
But so what do you use now for after extubation? You favor high flow or CPAP? That's a tricky question.
Yeah, it's a tricky question. Do you want me to get my own biases?
Yeah.
I think the evidence is clear, especially for patients less than 1 year. I would also, I'm sure that you saw the the review that was just published yesterday from BCCCM yesterday. I spent an hour overnight just to make sure that if you ask me this question,
No.
yes, but I think there was an excellent,
Well,
review.
the three authors were part of the guidelines. Martin Niever, Steve Shane.
Yeah, Steve was not.
Was not. And
yeah.
Alex Rota. Yeah.
But Steve, as you know, is very involved in respiratory support and published a lot about high flow and a lot of great things about clinical bronchiolitis too. So I think it's very interesting. The thing is, when you develop a guideline, again, there is this observational data that, and this is, I'm not a methodologist, but I will try to explain it as much as I can, that you have the observational data. And for quality, as we know all, that RCT will be higher in the guideline development. So if you have RCTs, if you have, especially if you have a big RCT, you depend on the RCT because they are higher quality. So you don't take observational data. Now, if you don't have RCTs, you take your observational data and summarize it as we did in the guidelines. So methodologically, that's how the recommendation would be made and taking the evidence. Now, high flow versus CPAP, I think you can read the explanation in the guidelines, and you can read the explanation also from the outstanding, I think, review from the team. And the thing is, with this, it's still a conditional recommendation with all of our guidelines. You need to put things in your context in your institution. So as the team summarized, people are more comfortable using high flow. They see benefit of it from preventing extubation in the bronchiolitis. Even the step up arm of the first ABC said that high flow is not inferior to CPAP. So it just the two things, the two trials have like a different recommendation in a way, but one was a step up, meaning that before extubation, and one was step down. So I think high flow people are more comfortable with. Is that right? It's more available. Maybe not some areas of the ward as I hear because it's expensive. You don't need sedation. People are more comfortable feeding patients on high flow. So it's a comfort level, and using sedation is another thing. CPAP for sure provide more support. There's no question. Physiologically, it's provide more support. There is issues with the mask in different areas for sizes of patients. Make sure that you have an inclusive fit, and then nutrition is a concern of patients. And then the third thing is the sedation. Concern about using sedation, and looking at what machine you connect your CPAP. Are you connecting your CPAP through a ventilator, or are you using, especially when you get to BiPAP, actually more than CPAP, but still, like with CPAP, how much support you get, and what kind of machine you use. So I think we still, when you go for implementation, you look at these things in your institution and see, are you able to get CPAP in your younger population without using much sedation. And if you look at the structure of the RCT, it's beautifully done RCT. The UK group did the sandwich and the first ABC trial. Fantastic work. There is also Oxy PICU that is coming. They are doing a great job. We can't say anything other than
they are leading the way in trial. In PICU trials.
Yeah, there is no way to say other than that is, they're fantastic researchers. But there's challenges with RCTs themselves, and as the group Steve and Alex and Martin, discussing the RCT itself, you ask a physician if they would extubate the patient to non-invasive respiratory support, and then you randomize a patient, and there is exclusion of some of the patients. And still you can see that there is more exclusion for CPAP because of, concerns from the physicians. And when you see the failure rates of the CPAP, it's related to sedation. So when you try to implement this, I think we need to work some of these kinks around to see, because we know that high flow is lower than CPAP and CPAP is lower than BiPAP for sure. We can't deny that physiologically for sure.
So Samer, it's been great this chat. It's been an amazing journey through this guidance, through the last 2 years with you. We finally meet in person this year, so in-person meetings are back. That's a good thing to live after many Zoom meetings, and now by Zoom, I think, thanks to you again. I think this is an awesome piece of work, this infrastructure of guidelines that you have led. So let's see what happens in the next few years in this area.
I'm very excited. And one thing that, just closing, it was a pleasure working with you, Sebastián. And I think building bridges, I think COVID, as you mentioned, was challenging. I think the team learned how to work virtually more. I think maybe this is maybe one benefit, and it connected us with different people from different areas, and having discussion with you and Martin and other people and experts in this area, not just about ventilation but other areas. I think it opens your eyes. I think this is one of the benefits of being involved in this. It's a lot of time for sure, but it's just connecting. It could be just, sometime I would ask somebody about a question that is unrelated to a project that we work on, or we might collaborate with each other in a different project. So there's a lot of benefits of building these bridges. Because at the end, what we are trying to achieve is getting better care for our patients. And our patients or our kids are not kids in Jordan or the US or Uruguay or wherever. It's our kids. It's humans.
Yeah.
We are trying to provide the best care for them, and getting the smartest people and the dedicated people together to work on improving this, and working on challenges, as you said, in different things. So I'm very excited about the work that we did, and very excited about more work and collaboration with you, the rest of the team, and the PICU community.
Thank you, Samer. Have a nice day.
You too.